Good evening and a very warm welcome to everyone joining us around the world to this event, the chance to rebuild to address the silent pandemic of cardiovascular disease. My name is Has Kachi, and over the next hour or so, I will have the immense honor and privilege to moderate this discussion. We are very fortunate to have an outstanding and truly stellar panel of some of the leading thought leaders in this space who will be contributing to the dialogue. But before I introduce the panel, I wanted to take a few moments to really reflect on the last 18 months or so. According to the World Health Organization, 2020 was a devastating year for global health. The fight against the COVID-19 pandemic has really left behind critical healthcare challenges that now risk triggering new health and economic crises. These are what we call the big silent killers, and they are cardiovascular, metabolic, and oncological diseases, whose diagnosis and treatment have really slowed significantly in the last period. The pandemic has exposed really the inequities in care across the healthcare system and how communities receive care, but also the impact on non-communicable diseases such as cardiovascular disease. We have seen fewer patients go to hospitals, fewer visits to patients seeing their physician to really get the care that they desperately need. When we think about cardiovascular disease in particular, this accounts for 1/3 of all global deaths, and they are estimated to increase from 80 million deaths today to over 24 million deaths by 2030. And this is despite the fact that the vast majority of these recurrent events are completely preventable. And we know that a major driver of heart attacks, strokes, and deaths is a type of cardiovascular disease called Atherosclerotic Cardiovascular Disease, or ASCVD, which really affects over 300 million people today. So it has never been so clear that there is a burning platform for change, and a need for the global healthcare community to come together to address the number one global killer. Prior to joining Novartis, I spent my professional life working across the various facets within the healthcare system, from my clinical work across primary and specialty care to working with clinical guideline bodies, patient organizations, and many, many more. So this is a topic that's very close to my heart. That commitment to work and collaborate with the broader healthcare system for the benefit of patients has really only been strengthened since joining Novartis. And what better time to have this discussion than today on World Heart Day. So today we will hear how movements in policy, clinical leadership, and patient engagement are needed to address the silent pandemic of cardiovascular disease. So for the first half of today's discussion, the panel will discuss, number one, the burden that cardiovascular disease places on patients and society as a whole. Number two, what changes are needed to transform healthcare delivery for cardiovascular disease patients. And in the second half of the discussion, we will move on to the Q&A. So I would urge you and encourage you to join the conversation and pose your questions to this excellent panel in the comments section that you see on your screen. So without further ado, I'll now introduce you to our remarkable panel. So we are very fortunate to have Professor Kausik Ray, who's a professor of public health and consultant cardiologist at Imperial College London, and also the current president of the European Atherosclerotic Society. Professor Rifat Atun, who's a professor of global health systems at Harvard University. Celina Gorre, who's the CEO of WomenHeart, a leading voice for women living with CVD across the globe. And Janneke van der Kamp, who's our head of Region Europe for Novartis Pharmaceuticals. So with that, Rifat, maybe you can kick us off. So we've seen the devastating impact of cardiovascular disease on the many millions of patients who are really affected by this. Could you provide your reflections on how COVID-19 has really affected this and the impact that you see on the broader healthcare system?
Yeah, thank you, Haz, and thank you for this opportunity to contribute with this outstanding panel on the World Heart Day. Yeah, it's useful to take a step back and look at the grim statistics. As of yesterday, there were 230 million reported COVID cases and 4.8 million deaths. And I'm sure these are hugely underestimated. But that's against the background of huge cardiovascular disease burden, the number one killer in the world, as you've said. The number of cases of cardiovascular disease doubled from 270 million in 1990 to 520 million cases in 2019. But again, this is a huge underestimate, as our research shows from Cascade's work that we have done. Secondly, the cardiovascular deaths have increased from 12 million in 1990 to 18.6 in 2019. and are projected to increase to 20 plus million in the foreseeable future. Along with this, the years lived with disability, and that's very important. Those who have cardiovascular disease and do suffer sequelae and effects have doubled from 17.7 million to 34.4 million years lived with disability in 2019. So these are very large numbers. With COVID, these numbers are going to be amplified, because with COVID, we saw that cardiovascular disease and cardiometabolic conditions were a major risk factor for COVID-19 morbidity and mortality. But also, we see the direct effect of COVID-19 on short and long-term effects on cardiovascular disease. For example, inflammation of the arteries and the heart muscle during an acute infection, and during resolving infection, continuing myocardial infarctions, inflammation, and myocarditis. And we still don't know what the long-term effects are going to be with long COVID. And what has happened with COVID-19 response really paints a picture of what has been happening with cardiovascular disease over many years. The response on the whole has been, if we are honest, and we should be, response has been ineffective, has been inefficient, has been inequitable, and has been inadequately responsive to the needs of specific groups who have the greatest need. Specifically, the effect of COVID-19 on health systems, on cardiovascular health, has been to interrupt prevention programs, those that existed, interrupt screening programs, again, the few that existed, reduce diagnosis, reduce access to healthcare services, which led to foregone care, delayed care, and when accessing services, suboptimal care. And this has produced a huge wave of unmanaged and undiagnosed cases, with many cases presenting late stage with worse conditions, with higher morbidity, and as a result, higher number of deaths, yet to be quantified. And of course, huge cost to individuals, their families, and to society at large. So COVID-19 has amplified what was happening in the past, has deepened the problems, and has further widened inequalities, with huge effects on vulnerable groups and women in particular, and Celina is going to talk about this. And if we look at the life expectancy on a paper published from researchers at Oxford University on Monday, in between 2019 to 2020, life expectancy in the 27 countries, mainly European countries, plus Chile and Norway, life expectancy has declined very substantially, with the exception of Norway. And life expectancy declined to such an extent that has not been experienced since the economic crisis, and in the case of United States, since 1933, which was the Great Depression. So we're seeing huge effects on our societies. But the question is why? We knew that there was going to be a pandemic. We just didn't know when. So why were we not prepared? Because I think this is very important to ask this question, so that we can manage cardiovascular disease effectively, which we have not, but also prepare ourselves for the future. Well, the first reason, in my view, is what I call asymmetric innovation. There has been an incredible renaissance of convergence in science, great science, all the way from molecular biology to genomics to data science, diagnostics, health technologies, therapeutics, you name it. Now, that accounts for about 20% of the expenditure, and this is where all the innovation is happening. In the remaining 80%, or even 90% in many countries, there's been little innovation. And Kausik will talk about this in terms of health service delivery. We're stuck in the past, unfortunately, and not much has changed. Of course, there's been improvement, and one should acknowledge and celebrate these. But on the whole, the change in policy and change in health service delivery has not kept up to pace with the remarkable innovations and their delivery into the system. The second is policy misalignment. On the one hand, we have industrial policies that push for innovation. On the other hand, we have health policies that are designed to constrain innovation. And third, in economic policies, health is seen as an expenditure rather than an investment that yields massive benefit sets for health, as well as for the economy, for societal well-being, and for the security of our countries. And the third is institutional logic. We are doing more of the same and expecting better results. As Einstein said, this is not going to work. This is madness. But he also said you cannot change the system with the same logic you use designing it. So we need to think differently to design a new system. We need to focus not on disease, as we have done, but on individuals and on prevention and maintenance of good health and improvement of good health. And we also free ourselves from the broken health systems that have captured us. So we need to run away from episodes of care to managing individual health over time, but also population health. So what can we do? Well, every crisis brings an opportunity, and COVID-19 is a shock, but it's also a wake-up call for us to do something that's going to be transformative. And we need to move from talking about the problems to generating solutions. And for this, I offer 5 I's. The first I is transitioning from intention to action. And I think there are some very important movements in this direction. They're encouraging the commission that former Prime Minister of Italy, Mario Monti, Senator Mario Monti is leading, is suggesting development of a global health board that takes into consideration economic and societal and security effects of health and the consequence of not investing in health. So it sets up a board similar to the Financial Stability Board. Very important, that brings together all the ministries at macro level. But we need to move from intention to action, do the walk rather than just the talk. Secondly, we need an integrated response. Integrated in the sense that this brings all of society approaches as well as multi-sectoral approaches, but integrated approach in terms of managing infections and chronic disease simultaneously, because at the end of the day, it's the same individual that's affected by these conditions. The third is inclusive partnerships. We need to come up with innovative public-private partnerships. And we've seen some very good examples of these in response to COVID-19. And we need to build on these partnerships that involve the public sector, the private sector, civil society, foundations, universities to develop a joint response to this problem. The fourth is investment in health. Demonstrating short and long-term benefits of health in terms of improvements in health outcomes, economic benefits, societal well-being, and security. And benefits that should be measured regularly and quantified. And the fifth I is innovation at scale. If we are serious about having impact at population level, we need to be able to scale up this innovation in health systems, especially in ensuring access to these innovations by vulnerable populations. But for all of this to change, we need to develop a new institutional logic. Business as usual just will not do. Thank you.
Thank you so much, Rifat. A really broad-ranging answer in terms of the real challenges that we see within the healthcare system. You spoke to the inequity that we've seen, and especially those who have been particularly affected, such as women and other kind of patient populations as well. Kosh, Rifat mentioned that we are stuck in the past in terms of healthcare delivery. From a clinician's point of view, what are the key challenges in terms of ASCVD management, and how can partnerships, the element that really Rifat brought up, how can that help address some of these going forward?
Thank you, Has. So I would agree with everything that Rifat has said. And if you think about our healthcare systems, they're actually geared up to treat disease and not preserve health. So if you want to preserve health, it's very simple. You've got to have to start about thinking earlier, you can actually do a lot more if you start early. If you basically start later with people with more advanced disease, you are going to inevitably have to do a lot more. And one of the problems that we have with that is that largely we're dealing with silent conditions. So a patient has a heart attack. 20 odd years ago, they'd have been in, or 40 years ago, they'd been in bed in a hospital, be bed rest and morphine. Now, patient leaves the hospital within 24, 48 hours sometimes. It's uncomplicated. They have a metal device put in that widens the artery, and they're not aware. Now, you've got a real issue because these people are going to be twice the risk of having future cardiovascular events. So actually bending that curve requires many, many different things. Patients' health literacy, advocacy, for example, from those affected as well. That yes, the person feels fine, but they're at risk of another event unless they change not just their lifestyle, but they're given appropriate medications. Now, the things that we often use don't actually make you feel any better or worse, but they work much more slowly to change your life course. And that whole understanding, both the patient, the recipient of the treatment that we're offering, the people delivering it, the healthcare providers, how that's delivered, where that's delivered, it's the complexity in all of those, particularly for conditions where you're going to have to target multiple pathways that make it really, really difficult to deliver. Now, the amount of information and the effectiveness varies quite considerably. There is this healthcare pyramid of primary care at the bottom, secondary care, and tertiary care. You don't want all of your patients showing up in tertiary care because these tend to be much more sicker, much more complex patients. So in an ideal world, you want most of your healthcare delivered in the community early on at scale. And that means we need both innovative treatments and the wherewithal to deliver it in the population. And those are just simply some of the challenges because there are so many moving parts and they have to work together. And if we don't find better ways of working together and just improve some of those efficiencies, we won't really tackle this problem globally.
Thanks, Kosh. So you spoke about the pyramid of care and actually how we need to start earlier. And some of the themes that were picked up also by Rifat earlier on in terms of the broader impact on the broader patient populations as well. So Celina, we've had some shocking numbers, over 18 million deaths every single year, cost to the healthcare system of over $1 trillion by 2030. That's what's expected. But beyond these shocking numbers, as a CEO of WomenHeart, from your perspective, what is the impact on patients and their caregivers?
Thank you for having us represented here today. Yeah, CVD affects all of us beyond the healthcare system. It impacts our ability to work, to care for our families and loved ones, and to contribute to society as a whole. Critically, it often occurs alongside other challenges like mental health, and that we've seen an uptick of that as well during the pandemic, and this leads to further morbidity and mortality. CVD poses also a very particular burden on women who play a critical role in caretaking within families, often looking after children and parents alike, in addition, oftentimes, to working outside of the home. And because improving cardiovascular health at the individual and familial level requires lifestyle changes from diet to exercise, stress management, and the like, these tasks, again, often fall disproportionately on caretakers, often the women in families. And what we've seen in working with women with heart disease is a surprising amount of stigma and self-blame, that their heart disease has resulted from them not looking after themselves, leading to further delays in seeking care and delays in sharing symptoms with their doctors, and sometimes even having a lot of guilt in sharing those symptoms with their own families, resulting in poor outcomes overall. I'd also say that cardiovascular disease among women suffers from, unfortunately, a decreasing awareness that it is the #1 killer of women, and also a lack of broad awareness about the differing symptoms of CVD in women. And so, all of this taken together means that, in this larger context that we've just heard about, women need particular attention as both patients and also as really critical caregivers in society as a whole.
Thanks, Celina. So we've heard a lot about the burden of CVD, the burden of ASCVD on both patients and the broader system. Janneke, from your perspective, what changes are needed to really transform healthcare delivery for cardiovascular disease patients as we look forward?
Yes, great question. And indeed, I think the previous speakers have very eloquently spoken about the massive burden of CVD. They've also already spoken about the fact that there are actually a number of great solutions available. And I recently heard a quantification of that statement. You know, there's a big unmet need and there are solutions. The quantification of this from Professor Pinto from the World Heart Federation. And he said, if we would just apply what we already know and the solutions that we already have available today, we could prevent 1/3 of premature deaths in Europe, 2/3 of which are cardiovascular deaths. And that was a European statement, but I'm sure it is true for many countries across the world. And it's just a quantification, I think, of what the previous speakers have spoken about. We have all these high-risk patients out there at risk of another cardiovascular event or even of dying. We have a lot of solutions, but somehow it's difficult to bring them together. It's a bit like a train. You know, you have a lot of capacity in a train. You have a lot of people on the platform, but when the train arrives on the platform, they all need to get through this narrow door, and that, you know, takes a lot of time. So the real challenge is, right, how do we bring these two together? How do we bring the solutions to the patients in need? And Rifat talked about 5 I's. Maybe I'll speak about 2 P's. One would be policy and the other one would be partnership. So I think it all starts with policy, right? With political will, with prioritization, right? If we really want to take cardiovascular disease seriously and have a significant impact, we need to start with the political vision, with the political will. And not only I think the political will to work on prevention, on lifestyle changes, etc. Of course, it's also needed, and there is already some attention, I think, in most governments on that topic. But specifically also on, you know, those patients that Kausik also talked about that have already had an event, those patients that are much higher risk of having another event. The policy would also needs to actually address those very high risk patients more specifically than only talk about general preventative measures. So that's on the policy side. And then we heard about partnerships before, you know, and you can ask yourself, why do we need partnerships? I mean, in my view, you know, relieving these bottlenecks is not easy. If it would be easy, we would have already done it. So you really need to bring together expertise, resources, thinking from many different players in the healthcare system. It's not a quick fix that one actor can just do by him or herself. So that's why I think you need partnerships. You need the policies, the public institutions, you need the patient organizations. And I would argue you also need private institutions and private companies like Novartis to really address all these complicated things that get in the way from these patients getting to these solutions. There's the whole triad of challenges there, right? It's education, it is patient identification, right? Patients might be lost somewhere in the system. They're asymptomatic often, so they don't come themselves. Like train, at least people come into the door because they want to go with the train. Those patients might be scattered all over the place. So education, patient identification, incentives in the system are often misaligned or objectives. There might even be administrative burden that Rifat also talked about to even make sure that innovative treatments can get to the patients in need. So it's a long list of bottlenecks that need to be overcome. Hence, I think policy and partnerships are really needed. And maybe partnerships, you know, sound complicated, and yes, they can be, but it is possible. We've seen some partnerships already happening, and one that I'm particularly close to is the one that we as Novartis recently announced with NHS England in this particular space of cardiovascular disease. So it is possible to bring different parties around the table and really fight for a common objective.
Thanks, Yannicka. Some really, really powerful messages there. So in terms of how do we start to get all of our patients off the platform and onto the train? We've heard about the 5 I's, we now hear about the 2 P's. And maybe this is a good point to kind of come back to you, Rifat. So we heard about the 2 P's around the need for policy and partnerships. And we've seen a real cultural shift happening, especially in the most recent period, over the COVID period right now, where, and you mentioned this earlier on, where health is no longer being seen as something, as an expenditure on a balance sheet, but more as an investment in our society. How did we get here? What are your reflections of how we got here, and how can we think about how we look at this going forward as well?
Yes, first of all, again, really great presentation by my colleagues, with which I concur. Taking a step back, partnerships, this is not a luxury. This has to happen. The question is, can we come up with innovative forms of partnerships? It's not a question of whether we should be doing partnerships. The question is, what kind of innovative partnerships can we develop? As we've seen with COVID-19, dealing with complex societal challenges, one has to bring together all the assets, capacity, and intellectual know-how and the technology available to combat and to address the fight. Address the problem. The same applies to cardiovascular disease, #1 killer, accounting for so many unnecessary deaths. Again, there are 2 certainties in life. One is tax, the other one is deaths. But many people die from cardiovascular disease too early, and many of these deaths can be prevented. So we need to pull together everything that we have in order to fight this #1 burden for societies. In relation to the change in the mindset or the institutional logic, we have seen the terrible consequences of COVID-19 on the economies of countries, on the social fabric of our societies, on the well-being of communities, and also the security of many countries. In many settings, there's been a complete meltdown, and still many countries are still struggling even to get fresh supplies and petrol. And this is happening in Europe, in the UK, no least. So we've seen the consequences of not investing in health. But also, more positively, there is now very strong evidence, and we've been doing some work with Whitefor Institute, and collaborating with colleagues at sort of G20 and B20 and H20 partnerships, to show not just the health benefits and quantifying these in monetary terms, but also benefits to economy, contribution to economic growth, and the spillover effects onto other sectors beyond health. And the returns are very large. So health is one of the best investments any government or any society can make.
So really, really clear messages there. Partnerships are not a luxury, they're a necessity. If we're truly going to combat big diseases like cardiovascular disease as we look forward, this is not a luxury that we can just forsake going forward. And we've heard about the consequences of not investing in health, and it's been very much highlighted the impact specifically on CVD. And we've heard this in the G20 Health Ministers Declaration, where they've spoken about the impact post-COVID on chronic diseases like CVD. Now, Coach, from your perspective, we've seen that there's been a disproportionate impact on cardiovascular disease patients. Could you tell us a bit more about this? Why is this? And actually, specifically, what are you and your colleagues doing to address this as well?
Yeah, I think that's really worthy of a little bit of time in terms of trying to understand that. So if you think about this, it's very simple. If you are metabolically more healthy, now that could be you're naturally metabolically more healthy, you've got a better lifestyle, you avoid various risk factors, and you've done that for long enough, that will allow you physiologically to be able to withstand the stress that comes with a powerful pathogen like COVID-19. And so, or a condition rather than like COVID-19. So in this situation, if you have risk factors that make you metabolically unhealthy, some of that can be mitigated by medications, by by controlling certain risk factors. And we've seen that those people that were on those treatments, it's not that the treatments were protective against COVID-19. What they did was they helped to try normalize your vulnerability. So that's really important. So that really also tells us that this is not the last infectious diseases pandemic that the world's going to face. It tells us that also that actually being metabolically more healthy naturally, or if you've got risk factors, controlling those better is going to put you in a better position. One of the things that we saw with COVID-19 was that essentially when the world was challenged, it was able to deliver. It took time. We started from zero. We were able to develop vaccines that one and multiple other groups developed. But that's great, but it's in a laboratory. Somebody's got to manufacture that at scale. That was important. Then you've got a supply chain. Then somebody has to deliver that, healthcare professionals. But the end user, the person, the citizen, has to want that. And so you've got all of those parts that had to come together in order to deliver the vaccination program that we've seen. But that started at the top with policy and policymakers having the will to do something relatively rapidly. And that's the sort of thinking that we're going to need if we're going to tackle atherosclerotic cardiovascular disease. So one of the things that we're delighted to have started and launched is the Council for Heart Health. And the idea of that is to bring together civil society, politicians, clinicians, patient groups, patients, and essentially to have an umbrella organization to start some of these discussions, to reduce those gaps, to look at who can we deliver and implement systems of care, whether that's new therapies, whether that's existing therapies, more efficiently at scale. And that's what we hope that we'll be able to do. And joining me in that are, I'm delighted to say, Rifat is going to be a key person with his knowledge of health systems. We've got from South Africa, Karen Sliwa, Richard Nethanonda from Johannesburg, and also Steve Nichols from Australia, from Monash, who is heading up an exciting program there. And there'll be many others that will join alongside G20 because we need the ministers, we need policymakers to listen, to then invest in that 10, 20-year cycle. Then we can redefine how we manage and prevent ASCVD.
So really exciting developments. Great to hear about the developments around the Council for Heart Health as to how you are bridging that gap between, as you said, clinicians, civil society, politicians, and patients to really address that those gaps between clinical practice and the guidelines. So, Celina, I come to you. So we've heard a lot about the impact on the disproportionate impact on lots of different groups, specifically women. Could you tell us a bit more about that beyond the clinical impacts? And you touched on that earlier on, but also we often talk about patient engagement, patient empowerment. Can you give us some good examples as to what does good look like?
Absolutely. Thank you for that. Yeah, and I just want to say I'm really excited to hear as well about the development of the council and the fact that patients will be involved as a primary stakeholder group. That's really music to my ears, and certainly to the patient community at large. I think that from our perspective, what's really critical here is that the patient's voice is heard. And this runs from the new council that's being developed, but also through to policymaking. One of the critical pieces of work that WomenHeart does is that it elevates the voice of the patient to make sure that it is part of any policy development, and to make sure that the lived experience, the true lived experience of the patient is part of the thought process and the development process of programs and policies. Really, really critical. I do want to share a few examples of how getting patients involved has created some really powerful and innovative programming. Organizations like ours run, the gamut of really creative innovation and programming, within the healthcare system and outside of the healthcare system. But one example here at WomenHeart is that our champions, which is what we call our volunteers, and these are women living with heart disease who are trained at the Mayo Clinic to provide support services to other women on their heart journeys. So these women work with their community hospitals to make bedside visits to women who are either just recovering from surgery or just have survived a heart event or have had a heart procedure. And they provide these patients with information about thrivership, not just survivorship, but thrivership. What does it mean to thrive with heart disease? And they are also provided with an invitation to have ongoing peer support, from monthly meetings all the way through to one-on-one support. And it's really as they prefer. And this support continues once the patient is discharged to encourage them in the medium term in their recovery journey, but also in the longer term in terms of rehabilitation and long-term adherence to their treatment regimens. And it turns out that these examples of programs, it makes outcomes better. So women who participate in these programs have better outcomes than those women who don't. So I would just really encourage folks who want to think about how to extend the lives of patients in their community to really truly engage patient groups.
Thank you so much, Celina. So we will now go to the Q&A. So a question for you, Kosh, that's just come through. And again, to everyone out there, please keep bringing the questions in. We will obviously ask all the panelists here as well. So Kosh, we've heard about the gaps between the guidelines and clinical practice. So building on your experience, you're the president of the EAS. What are your reflections in terms of what are the main challenges in ASCVD management? And what are your recommendations to healthcare leaders and scientific societies of tomorrow to bridge that gap between the guidelines and practice?
Yeah, and that's something we've seen for a long, long time. And it's frustrating because, we do the trials and it tells us that we should be doing X and Y. Guidelines then come out, but then it's always left to somebody else to try and institute. And we never actually try and look at the root causes. Now, if you look at the root causes of that, some of that may well be to do with, for example, health literacy, awareness of the importance of achieving those guidelines. So both for the patients and also the deliverers. There may be issues with access to treatment. So there has to be some way of equitable access to treatments for all. And most in particular, when innovative treatments that come along, that they need, because usually there's often barriers to innovation. And some of those need to be offset, and we need to make those really much more streamlined so we can actually get those at highest risk, the appropriate treatments early to reduce those equities in care. But I think at the moment we need a system to basically work together instead of this is what you should do. Now you find the solution. That hasn't worked for 20, 30 years. The solutions have to be offered so that they can be implemented much more easily at scale and in the community, not just by specialists.
Thank you, Kosh. So we've another question that's just come through. Maybe we'll give this one to you, Rifat. So we've talked a lot about the impact of COVID and the pandemic. So do you have any statistics or any data as to what is the impact of COVID in terms of increasing the rate of cardiovascular events? I know there's been some data from Harvard specifically, but yeah, what are your reflections on this?
Yeah, actually, we're in discussions with colleagues at OECD, Organization for Economic Cooperation and Development, and Nick Klazinga and his group in the University of Amsterdam. They're undertaking a review, and there should be some results coming through, which will feed into a report that we're jointly doing with OECD. So watch the space. We're looking at the published literature to date, but the effects are very substantial. 40-50% decline in access, and we're trying to think how we can translate this into or project this potential impact on morbidity and mortality. We've done similar work for cancer. For example, a recent paper we published looking at impact of COVID-19 on cancer, purely looking at delayed diagnosis, which leads to presentation at later stage. We're able to demonstrate that there is a decline. There's a decline of 15% so there's an increase of 15% in mortality for the 5 cancers that we looked at. So for cardiovascular disease, it's likely to be as high, if not higher. And that was just looking at delayed diagnosis, not delayed treatment or suboptimal treatment. So the numbers are going to be very large. So I think, and I hope this is going to be a wake-up call to policymakers that we really need to do things differently, because at the end of the day, it's the citizens, it's the patients who are taking the brunt of these shocks to the system.
Thank you, Rifat. So, Yannicka, I'll come back to you. So you mentioned the 2 Ps, and one of them was partnerships. So we know that Novartis has been really at the forefront of public-private partnership approaches and you mentioned it earlier on, with the world's first agreements with the UK. Can you tell us a little bit more about this? And specifically, why are Novartis embarking on such a different journey?
Yeah, thank you for the question. It's indeed, I think, a good example of how a partnership can come together. And it all started with that first P from the NHS side, with their vision of their realization, right, that cardiovascular disease is their main killer, same as in many other countries, and that it's actually a killer that they could address. So it all started with that vision. This is something we can actually do something about. We have the solutions available. We have a lot of patients at high risk. We can have a major impact here as a healthcare system. So that's where it started on the NHS side. And then, of course, on our side, we have a long history in cardiovascular disease also as a company, and also therefore a long history of somehow frustration with the bottlenecks that we spoke about before, with why do innovative treatments not reach the patients that are in need faster and in a more equitable way. So based on these 2 ambitions, we started to discuss whether there could be a common ground, right, between what the NHS was trying to achieve, what we were trying to achieve in terms of faster access to innovative medication. And we actually found the common ground. And that's always, I think, the first prerequisite of a partnership, making sure that, there's transparency and clarity on what the different parties' motivators are. Once you have that, you can see if there's common ground and whether you can form a joint objective, a joint ambition. So we found the common ground. We set a joint objective. We want to make sure that hundreds of thousands of these very high-risk CVD patients get treated appropriately. And with that, the NHS calculated that they could save 30,000 lives and prevent 55,000 cardiovascular events, strokes or heart attacks in the next coming years. So then we said, okay, we know that it's possible. We have an objective. Now, what do we need to do to remove these bottlenecks? And we pooled our experience and resources to really address each of these bottlenecks. What do we need to do, and who is the best party to drive education, to identify the right high-risk patients, right, to make sure that they come into the system at the right point in time, to remove other obstacles that there may be at a system level or at a primary care level. That's really what this partnership is about, starting with finding the common ground, setting a joint objective, and then together working on removing all the obstacles that would normally be in the way.
Thank you so much. And it's really, really inspiring to hear that partnerships are not only feasible, but they're very much alive and kicking and actually really making an impact on such a huge population as well. So, Rifat, there's a question that's come through regarding this element of communicable, non-communicable diseases. So we're in the middle of a pandemic. So should we be focusing on non-communicable diseases while we're in the middle of a pandemic?
Excellent question. And, this is a perennial question. Actually, the issue is not communicable versus non-communicable. It is the individuals. It is the individuals who are affected by communicable disease and non-communicable disease. And as we heard, and Kosh has elegantly stated that, those with poor cardiometabolic status were the ones who suffered most from COVID-19 when they were affected by it in terms of morbidity and also in terms of mortality, but also those with socioeconomically disadvantaged groups were the ones who also suffered most, including the elderly. So the question is not communicable versus non-communicable. We need to strengthen health systems. We need to have strong primary care, We need to have a very strong community level response. We need to be able to mobilize citizens, not just patients, but also citizens. And we need to ensure that we're able to deliver care seamlessly for individuals in a way that is responsive to them, and interventions that are effective, that are efficient, and that are highly equitable. And this question also applies to prevention versus treatment. It's not either or. Both need to happen. We need to be able to manage the whole care continuum, all the way from developing health literacy, investing in health promotion, maintenance of good health, prevention of disease, screening, preventing progression of disease once it has happened, and managing disease effectively to prevent premature mortality and morbidity. So the issue is not diseases, and that's the institutional logic we need to change. We need to focus on individuals and delivering care through strong health systems underpinned by very strong primary health care.
Fantastic. So Celina, maybe I'll come to you. There are two similar questions that have come through on the chat. So one is around what are the key ingredients to be a catalyst in terms of partnerships and creating awareness. And the other one is really, again, and this is again, very, very similar theme. Can you share your reflections and the role that patient organizations have in shaping new interventions and programs? We've heard about partnerships and the impact they can have. What are the biggest roadblocks? What can we do going forward?
Thank you for that. Thank you for those questions. I will say that one thing that policymakers should know about patients right off the bat is that they have a fire in them to participate in the policymaking process. They not only want to be heard, but they want to be a fundamental part of the conversation. And they are themselves, living the experience, so they can tell you firsthand what their needs are. And I think that is going to be, a critical component of our success. If we are to realize those successes, that's got to be a critical part of it. The biggest roadblocks in my mind are really roadblocks outside of the healthcare system. Healthcare systems sit inside community systems, sit inside societal systems. And within these systems, we have to have even more silos broken down. We have to have even more collaboration, not just between policymakers and health systems, but we also need to have partnerships with food producers. We need to have partnerships with companies that look after sports and parks, so that all of these things are joined up. Because as we've already said, social determinants of health are so far beyond what happens in a hospital setting. So my sort of reflection is that patients need to be involved from the outset all the way through to the beginning, involving more sectors than just the healthcare sector.
We just had a follow-up question to come back to you, Celina, actually, from the chat. So building on what you just mentioned, how can we bring patients as partners in all this? How can we bring them forward? You mentioned they have a fire in them, then they want to be heard. Yeah. Can you give us some tips and some ideas as to how we can bring patients forward?
In today's day and age, the internet is a blessing. And the reason I say that is that patients are organizing themselves. If you go on Facebook and you look at the groups that are formed, they are forming around all sorts of different disease states. And heart disease is no exception. And in particular, folks that are experiencing similar things. And in our case, women experiencing delayed and misdiagnosis of heart disease is something that catalyzes women to come together, to say, hey, I had that experience of not being believed. Have you as well? Oh my goodness. And that understanding and realization that these experiences are shared, really, again, lights that fire even further. And so I would say, reach out to patient organizations, because patients are finding them each other. They are building organizations, they are coming together, and they want their voices to be heard.
Great, thanks, Celina. So, Janneke, you talked about partnerships and you spoke about the UK agreement. Maybe, Coach, I'll come to you in terms of, you are a clinician living through this. So from a first-hand perspective, what does this kind of collaboration mean to you and more specifically to your patients and the broader healthcare system?
Yeah, I think you've got to take a step back here, that before we actually deal with that side of things, there's a whole system-wide change that needs to be looked at. And so probably the best thing I could probably give you is an example. And this really reiterates Nelson Mandela's quote about, if you want to walk fast, you walk alone. If you want to walk far, you walk together. So I can take an example, an inherited condition, high cholesterol, and exists in every corner of the world, prevalence 1 in 311. There are regions of the world that haven't looked for that. So we started off because we need to collect enough data to be able to convince policymakers to invest in screening and finding people early. So it took 5 years. We collected data in every region of the world, and that basically showed that for a genetic condition, the average age of diagnosis is 45, 46, with a lot of people already having cardiovascular disease already present at that point. Now, on its own, that is not enough. It's great because countries now started to develop their own data and their own registries. We create that infrastructure, people to go at national level. But what we brought in also were patient organizations, FH Europe, because they are the advocates for those patients. And together, for example, we've been able to work collaboratively. And on the 11th of October, we have a technical meeting under the Slovenian presidency in Europe to talk about using these data to say, why don't we just think about screening, universal screening for cholesterol before the age of 20, preferably before the age of 10. So that is a really good example of how you can take collaborations. Now, when we find these people, we've got to think about what we do with them, how we manage them. That's going to require a systems-wide change, not just in terms of resource, newer, maybe more clinics, but effective ways of delivering that in different regions. We've got large populations to cover, as well as newer therapies that may be needed for those individuals. And that's a good example of a catalyst that actually can get system-wide change.
Fantastic. Thanks, Coach. And actually, just on that theme, we've had another question come in, which is kind of a similar theme. We spoke a lot about, I think some of the things that were mentioned earlier on in this discussion is the need to move from small-scale projects to really innovation at scale and really large-scale projects. So maybe this one's for you, Yannicka. In your experience, what is needed from industry and the broader healthcare system to deliver innovation at speed and scale to patient populations, aiming to reverse this current trajectory that we see with CVD mortality?
Yeah, so that's a big question that I think we've been debating about for the past hour. But maybe to add something that maybe we haven't discussed as much yet is the amount of different stakeholders. I think many people touched on it, right? It all starts with understanding who to involve, actually. Right? There's so many different players in the healthcare system. So if you want to really address these bottlenecks, you first need to understand who can actually address these bottlenecks, right? Just political will is not enough. You need to make sure that all the parties that need to be involved are involved. So that's, I think, the starting point. And then it is what I just talked about in terms of how we started with the NHS. Be transparent about everybody's motivators and objectives and obstacles. Put everything on the table so that there's full transparency. Because only then can you have trust between all the different parties. And only then can you try to find the common ground, right? So identifying who the relevant parties are, making sure that everybody's motivators, drivers are on the table, that we have transparency and trust, and then start working together on the objectives. And once you have that set, what's the shared objective, you can start filling the how in, right? Who has expertise in education? Who has expertise in maybe digitally identifying patients? How can we pool the resources to reach that objective? But not an easy journey. But I think we already mentioned that, right? I think the quote from Mandela is very appropriate here. If you want to go far, you have to go together, and it may not be a short sprint. I think Rifat wants to add. I see his hand waving.
Yeah, no, Janneke, I really wanted to echo what you were saying. Absolutely right. I mean, there aren't off-the-shelf solutions. And this is what I mean about innovative partnerships, integrated policy responses, investing in health and innovation at scale. So we have to change our institutional logic. We can't just go and find on a shelf a solution that works in one country that's going to work in another country. But even in the same country, what works in north of England is not going to work in south of England. But even in south of England, what works in one borough of London is not going to work in another. So, but there are a number of principles we can pursue that Janneke has already alluded to. One is building coalitions for joint problem identification, because it needs to identify a problem that needs to be resolved by everyone. Secondly, co-designing these solutions. And here, citizen and patient engagement is key, because especially with chronic conditions, because they are the ones who are going to be living with these conditions for 30, 40, 50 years, if not longer. So they really need to be in every stage of this process, policy making, but designing the intervention process. Third is participative delivery that brings together community, primary care, and secondary care. And we have some of the tools using integrated care pathways, but also use of new data capabilities that we've generated to better stratify populations into different groups so they can be provided with targeted interventions. And finally, we need to be able to measure what is working and have an agile response. So we learn continuously, develop these learning health systems to improve and change all the time, and then replicate what has worked or core element of what has worked elsewhere, but continuously learn. It's a long journey, but quoting a Chinese proverb, a journey of 1,000 miles starts with the first step. But obviously not alone, as Nelson Mandela has said.
It's a really, really powerful message. What we heard there was around this post-crisis era, there's an opportunity to rebuild. We've heard quotes from Mandela, Chinese proverbs, but it really was about building coalitions. And as we come to the end, maybe I'll come to each of my panelists, actually. Maybe you can give us your final reflection. We've discussed a lot of things, but maybe we'll start with you, Coach. What are your final reflections?
Yeah, so if we're doing quotes, then maybe I'll quote Daenerys Targaryen from Game of Thrones. We've got to break the wheel, because this cycle that we've been going through continuously again and again, it doesn't change. So we need to actually do this in partnership with the right people. And as a number of people have said, is just be honest and think long term. There isn't going to be an off-the-shelf solution. It's collaboration, and it's thinking outside the box with every single stakeholder.
So, Celina, how do you follow up Daenerys Targaryen?
Well, I'm going to marry up Rifat here. I think that's a worthy follow-up. So I'm going to use 3 of your 6 I's there, Rifat. Once you have the intention to action, I would implore you to consider integrating passionate patient organizations like WomenHeart into inclusive partnerships. So I think I got 3 of the 6.
Good.
Rifat?
No, I mean, who can follow Kosh's comment? But I agree, broken wheel. We need to develop a new institutional logic, because more of the same is not going to work. And I really want to stress this sort of 5 I's again. We need to do less talking about more action, move intention to action and learn from it. There's no perfect solution. We need to implement and learn. Secondly, integrated policy response that really involves all the stakeholders. Third, and inclusive partnerships. Citizens and patients are key to that. Fourth, changing the narrative from cost and expenditure to investment in health and measuring the benefits. And finally, innovation that can be achieved at scale to benefit everyone.
Thank you, Rifat. So, Janneke, the final word to you.
Yes, I'm also not going to try to top the quote there, but maybe I come back to my train metaphor. I'm an optimist, right? So yes, there's a massive burden, but what I'm optimistic about is that there are so many solutions available. It is just a matter of making sure that bottleneck gets widened, right? That door in the train is getting opened further. So I come back to the two P's, right? What we need to do that is policy, and not just policy in primary prevention lifestyle, but specifically targeted at those high-risk cardiovascular patients. And then partnerships. I like what Rifat said. It's not a luxury, actually, it's a necessity. And we are very open to enter these dialogues, of course, also in different countries around the world.
Thank you very much. I'd like to thank all of the panelists today for such a rich conversation on how we can really address the silent pandemic of CVD. We had lots of different themes today. We heard today that the COVID-19 pandemic has really unmasked the broader healthcare system challenges that really have existed for some time already. These include inequities in care, especially across vulnerable populations, but they also include the gaps that currently exist between guidelines and clinical practice. But as we heard from Janneke at the end there, we also heard that there are real signs of optimism, that we need to continue to shift from short-term projects to rapid adoption of innovation at scale. The partnerships, as we heard today, across the healthcare system are not only feasible, but are very much coming to the fore and addressing high unmet need across large populations today. If this pandemic has shown us anything, it is that in this post-crisis era, there exists an opportunity to really rebuild. Just in the same way as we saw the world come together after the financial crisis in 2007 with the development of the Financial Stability Board, in the post-COVID-19 era, there's an opportunity now for the world to come together once again to address the largest healthcare crisis that systems and governments will face in the next 20 years to stem the tide of cardiovascular disease. Now, to achieve this, we will need to come together to build a movement in policy, clinical leadership, and patient engagement. So finally, I'd like to thank you, to give you my sincere thanks to everyone who joined today, for those who posed questions, for those who are part of the discussion today. We hope that we are one step closer to taking a chance to really rebuild to address the silent pandemic of cardiovascular disease. Thank you.